Keeping EHRs error-free, the value of patient engagement. This program is part of our series on consumer engagement. This is Kate Berry, CEO of National eHealth Collaborative, or NEHIC. NEHIC is a public-private partnership with a mission to advance nationwide health information exchange to improve health and health care, including providing education on health IT. We also convene the Consumer Consortium on eHealth and the HIE Learning Network. Today we have an outstanding program for you with a very interesting panel of speakers. We'll be introducing them very shortly. Next slide, please. First, I'd like to highlight a few of our upcoming NEHIC University programs. We have an advisory council who helps shape the curriculum, serve as faculty, help to recruit faculty, and provide additional advice to us. The council has representation from virtually every segment of healthcare and is an extraordinary group of people with diverse perspectives and expertise. We're really delighted to have them as part of our extended team. Next slide. NEHIC offers a wide variety of education programs, including Spotlight Learning Series on Health Information Exchange, Spotlight Learning Series on Consumer Engagement, Spotlight Learning Series on the Beacon Communities, Careers in Health IT, ONC Initiatives, and Trends in Health IT Innovation. Next slide, please. The next program in our Spotlight Learning Series on Consumer Engagement will be on Tuesday, May 15th. The program is entitled Innovative Consumer Engagement in Behavioral Health, the Centerstone Substance Abuse Project. Centerstone is a nonprofit organization providing a wide range of mental health and addiction services. Recently, they received a grant to implement a web-based recovery-oriented system of care that will improve access to substance abuse treatment services in Indiana. Panelists will discuss the Centerstone project and the impact it will have on behavioral health and addiction services. Next slide, please. You can download and print the slides from today's program at the URL on the screen. And next slide, please. I think we're a couple slides behind. So during the program today, please do submit your questions as they come to mind by entering them into the Q&A window at the bottom right side of your screen. And at this point, so we'll have a series of presentations, and then we'll open it up for Q&A. So again, please enter your questions as we go along. And now I'm going to turn the program over to Erin Petter, Consumer eHealth Policy Analyst for ONC, who will kick the program off with a brief overview and introduction of our panelists today. Erin?
Thanks, Kate. Good afternoon, everyone. I'm joined here by Lygia Ricciardi, who's our Senior Policy Advisor for the Consumer eHealth Program, and she'll be available at the end of the presentation to participate in the Q&A. So I want to welcome everybody to today's discussion, and thank you all for joining. I'm just going to give some brief introductory remarks to sort of frame the discussion, and then I will introduce each of our distinguished panelists. So to start, one of the primary objectives of ONC's Consumer eHealth Program is to increase patient access to information and their availability to use that information to improve health and health care. Now, the research shows that patients want to review their records and cite the ability to do so as one of the most compelling reasons why patients would want access to their health information. So as EHR adoption increases and providers are implementing meaningful use objectives, we anticipate that the number of queries about the information's accuracy and completeness is expected to grow. This presents an opportunity for patients access to information in the medical record to help ensure that the data our trusted providers rely on every day to make important healthcare decisions is complete and accurate. So to further the thinking in this area, ONC funded a project with NORC to determine the utility and scalability of technologies that facilitate patient engagement for improving the data quality of EHRs. And as part of this project, NORC conducted an environmental scan of existing and emerging technologies to assess how patients can interact with their providers to improve the accuracy of their medical records. And they also set up a pilot with Geisinger to test the effectiveness of medication reconciliation through the use of a patient feedback form. So the purpose of today's webinar is to share what we've learned thus far and also to ignite further discussion on how we can more fully leverage patients and families to help improve the data quality challenge that we face. So as our national coordinator, Farzad Mostashari, is very fond of saying, we have 1 million of free fact checkers on standby who are at our disposal to help with quality control of the information in the record, if we can only figure out the technologies and policies to allow those people to participate more fully in this process. The findings of this research project will have relevance to inform future stages of meaningful use and related standards and certification criteria regarding how patient-generated data is treated. So we look forward to your comments and questions at the end. But to start, I'd like to briefly introduce our distinguished panelists. Leading off the discussion today, we have Dave DeBronkart, who's widely known as ePatient Dave. Dave advocates for patient empowerment and letting patients help. He's an activist for the transformation of healthcare through participatory medicine and personal health data rights. We also have Priscilla Dulab, who's the Health IT Program Area Director at NORC. Priscilla has conducted a number of program evaluations of public health departments, personal health records, and state health information exchanges, among others. We also have Norman Sondheimer, who's the co-director of the Electronic Enterprise Institute, EEI, at the University of Massachusetts Amherst. Norm has been active in areas such as computer-mediated deliberation, equipment health management, EHRs, and online dispute resolution. Ethan Catch is the director of the National Center for Technology and Dispute Resolution. He's also Professor Emeritus of Legal Studies at the University of Massachusetts and has pioneered work on online dispute resolution across several industries. We also have with us today Ken Mandel, who's an associate professor at Harvard Medical School and director of the Intelligent Health Laboratory at the Children's Hospital Informatics Program. Dr. Mandel's work has explored areas like personally controlled health records, disease outbreak detection, public health surveillance, and national health information infrastructure. So without further ado, I'd like to hand this off to ePatient Dave, who will make a passionate plea why this is a big deal and how patients and families can help.
Well, thanks, Erin. Who, me, passionate? I'm very grateful that ONC and NEHIC have seen fit to start this with the patient's perspective. It's kind of ironic that in preparing for this, things happened. There were typos, So, for instance, I'll mention late in my talk, Ethan's name was misspelled, and I copied and pasted it into my blog post about it. And we'll talk about an idea, the perpetual lie, and even a blog post from 3 years ago titled The Wicked EMR, about how these things happen. And even with the patient orientation of this, my name was left off on the list of presenters on the opening slide. Things happen. I grew up in typesetting. Okay, we had a thing called proofreaders, and it was a matter of faith that you cannot proofread your own stuff, because the mistakes that you made the first time, you're likely to repeat. You have to have a second set of eyes. I have way too many slides for my available time, and I see that the system has a little delay on clicking. So everybody just ride with it freely. This will be like jazz, and it'll all be fine on the archive. Click the next slide, please. I love information. I love data. Okay, next click. Data, as part of my typesetting career, I developed the software that runs the plate make software for this business card service company that makes business cards and stationery in very high volumes. We worked out ways in the 1980s to do things that everybody said were not possible. And we did it using data. But one thing we learned is the data has to be clean, or you end up high-speed malarkey. This graph now is my, this is when I was sick with cancer. I decided I'm the kind of guy, I made a spreadsheet to keep track of my tumor sizes. Next click, in fact, with good software, you can even graph it and get a better feeling for how the trends are going. I see that with a heavier graphic slide, there's a little more delay. Next slide, please. The problem with data is that if it's wrong, it can be lethal. Here's a graphic from a story that National Public Radio did last year on how bad GPS data led somebody to their death. It can happen. The more we come to trust data, the more important it is that it be accurate. Click ahead. My mother's own case when she had a hip transplant last year, when she was transferred to rehab, her hyperthyroid got copied wrong as hypothyroid. It could have been fatal. As the slide says, you know, that what I realized is the purpose of recording any information in a computer or on paper is so someone can read it later and do something based on it. Now, I'm not saying that everyone actually reads today everything that's in your paper medical record or electronic, but the point is the only reason to put it in there is for somebody to do something based on it. So that means, click ahead, the data must be clean, and click again. I'll quote my friend and colleague Trish Torrey from Every Patient's Advocate about, they often tell me that once they have gotten through a medical problem, there are errors in the record or missing information. Click ahead twice, please. The data must be current as well. So now, Hugo Campos is a member of our Society for Participatory Medicine. Many of you on the call may have heard about him, but I want to jump ahead beyond the quality of the data to how relevant it is to the task at hand, because really that's what we're looking at here. You know, it does no good for a physician to have access to information that is wrong, and it does no good for any of us to have access to information that's way out of date. Now, Hugo, click please, has a defibrillator planted in his chest. He's got bad electrical wiring in his heart, and so his heart starts fluttering, fibrillations, all kinds of things that I don't know how to pronounce. And so we have this marvelous gadget implanted that will sense the problems and do the right thing. Now click. His doctor gets real-time reports of what's going on in his heart, real-time or at least overnight. He has a bedside monitor that downloads the data and sends it to his doctor. Click ahead. What Hugo sees, though, is he doesn't see diddly squat until he goes to the doctor's office 6 to 12 months later. Now, you might say the gadget's purpose is to keep him from dying, to help his doctor keep him from dying. And in one perspective, that is true, but it's not useful for managing his condition in real time. Click ahead. Because you know what he'd rather do? He would rather not have the stupid symptoms in the first place. We are, after all, talking about health here. Your mother's health, your kid's health. Yes, I get passionate about this. It really matters. So what did Hugo do? Click. He happens to be a web developer. He's not a real engineer or programmer, but he put together a little web form that he can access on his iPhone and keep track of what he was doing when these episodes happened. So and it feeds into this spreadsheet, so he can see, he figured out on his own, because it's real-time data, that drinking Scotch whiskey gives him atrial fibrillation. So now he doesn't do that anymore. That's the value of real-time data available when you need it. However, click, most patients can't do that, you see. So, and what we want, click, is we want just don't give us this a month after discharge. This is a particularly timely slide because, as many of you may know, this week the American Hospital Association announced that they don't like the idea of giving us our medical records at discharge, They actually wrote to ONC saying, please give us a month, because they actually said we can't figure out, it will take us a month to figure out how to respond to a request. Well, for heaven's sake, folks, let's get the pitchforks. Next slide. I had a small data quality error myself. You'll notice that here, this is a radiology report from 2003. The records, my name's Richard Davies de Bronkart, but it still identified me as a 53-year-old woman. And not only that, but 2 doctors signed and certified that it was correct. Well, you know, things happen. I know from typesetting you can't expect people to be perfect. The question is, what do you do when you find a mistake? And can we put something in place to help improve quality? I say let patients help. There's another dimension of this. Moving ahead to Gawande's slide, the famous surgeon, his commencement address at Stanford a couple of years ago, click, was the story of, in fact, click 4 times, please. Dwayne Smith, the grocery store manager who had a horrible car accident. Long story short, he was a medical miracle. They saved him, but there was one mistake. They forgot to give him the vaccines that everyone should have when their spleen is taken out. As a result, he had a horrible infection that swept through his body a couple of years later, and he lost all his fingers and toes. And the question here, you can think all you want about why isn't healthcare perfect, but the question is, what if the care team had shared the care plan so the family could see it? And then somebody might have said, you know, hey, wasn't he supposed to get some vaccines? And click ahead again. It turns out at the IHI forum a year and a half ago in Orlando, we were discussing this, and the people at Abington Memorial Hospital in Philadelphia said, we did that. We did that. It's just a simple printout report from the EMR record. They show it to the family each day. Here's what we're going to be doing. Click. I asked, does the family ever find mistakes? And they said all the time. So look at that. The most motivated, as Farzad says, you know, the most motivated proofreaders, improving data quality just because the hospital invites them. As I wrap up, as I come close to the end here, my next slide, I realized this morning, and I said in a blog post, bad data is an infectious disease. All right, first click. I'm in South Carolina, Greenville, South Carolina right now, where the University of South Carolina Medical School is opening a new location in Greenville starting in July. And I was talking with Mike Fuller, who's running the program, and as we were discussing this, he said, yeah, we have this idea of the perpetual lie, something that goes in there and then just gets copied and pasted. That brought me back to 3 years ago. David Kibbe with the American Academy of Family Practice wrote a blog post on ePatients.net, so you can get at it with this URL, about the wicked EMR. And he talked about how when printing was new, there was a typo in one batch of Bibles that was printed. They left the word not out of the commandment that says, thou shalt not commit adultery. And let's just say that the king was not pleased. And it was the first instance, he points out, of where technology enabled an error to spread like crazy. And so he talks at some length about the wicked EMR as well. And then finally, Ethan's name was misspelled in the email about this webinar, and I earnestly copied and pasted it, click, click. So this stuff happens, and we can stop it. So next to last slide, the purpose, remember, the purpose of putting information in any system, in any technology, is so someone can read it later. This is happening to your records, your mother's records, your children's records. We better help improve the quality of data. Please let patients help. Thank you very much.
Thanks, Dave. This is Priscilla. Hello, everyone. We are delighted by this opportunity to share our findings from this very important ONC-funded study where we've been looking at engaging patients in improving the quality of information in their health records and the role of technology. So I'm the project director for the study, and I'm joined on this webinar by my collaborators from the University of Massachusetts. And I look forward to engaging in a very active Q&A at the end of this presentation. For today's talk, I'm going to discuss broadly the goals of the study and very briefly what we did. And then Norm and Ethan will get into some of the details of the findings, and then we hope to wrap up with some implications on policy and practice. Next slide, please. So one of the policy priorities articulated in Stage 1 Meaningful Use is engaging patients and families in their healthcare. There's a general belief that patient engagement is associated with increased adherence to treatments and prescriptions, better management of chronic conditions, improved compliance with recommended preventative healthcare practices, and all of this is done with the goal of improving outcomes. Also, as discussed and mentioned by the speakers before me, allowing patients to view their records is intended to have beneficial effect on the accuracy of these records. So for this ONC-funded project, we looked at the data quality problems that may come to light following increased patient access to health information, understanding and recognizing that data quality problems exist today in all records, both paper and electronic. We assessed the current state of the field by looking at what organizations are doing to obtain patient feedback when they give patients access to their medical records. We identified, specific challenges for providers and really opportunities for, work like this and others to inform how things move forward. We explored solutions being pursued by leaders in other industries and, try to identify where healthcare can leverage what has been learned already by other industries. And finally, we assessed the legal landscape to understand, where these solutions might fall and what the implications are. So we conducted the study with an extensive review of the literature. We also had a series of discussions with key informants, which included small ambulatory practices, patients and their advocates, vendors, patient privacy officers, and thought leaders with various large healthcare systems. And finally, we did a detailed review of 8 patient portals, which we'll discuss as we get into the discussion today. And what we found that while it is still early days, there's some really important work being done and progress is being made, and there's a lot to build off and that the timing is right. So I'm hoping as we go through the rest of the presentation, the value of what we learned will come through and, set the stage for things to move forward from. Next slide, please. So just very briefly getting into some of the findings. In a national study conducted by the California Healthcare Foundation in April of 2010, when users of personal health records were asked what is useful about their medical records, what was ranked highest by patients in terms of usefulness was making sure that the patient information is correct. And that's what you see in the slide in front of you. Interestingly enough, in the same study, when non-users of personal health records were asked if they had access to their medical information online, what would they be interested in? Non-users were similar to users in that they were most interested in checking to see that the information was indeed correct. Next slide, please. So in another study, Marco conducted 2 surveys, one of providers and one of patients, and this was done in August of 2011, in August of 2010. And results showed that both patients and providers were in agreement that it's important to have a clear process to request corrections to their medical records. So with that said, I'm now going to hand it over to Norm, who will get into more of the specifics on the data quality issues and what we learned in our review of patient portals. Norm, over to you.
Oh, thank you, Priscilla. The next chart, please. It's a challenge in complex fields like medicine to achieve error-free records, whether they're stored on paper or stored electronically. Many studies have proven this point. We've included 3 to give you some idea of the opportunities for patient feedback. The first on the list is a survey that looks at recent studies of data quality of medication lists and electronic record. These shows that there's errors of omission or missed medications from between 27% and 53% of the patients. Two studies of inaccuracy show patients are very likely to have data entered that needs to be updated. Although we have to caution that definition of omission and inaccuracy don't agree across all the studies, the magnitude of the value shows the need to continuously work to improve medication list accuracy. And that's what the medication reconciliation movement has been doing, and certainly patients play a key role in that. And what we're talking here is about patients giving online feedback between office visits. Next, looking at the history of procedures shown in CPT codes, the Military Health Services TRICARE program has data quality managers at each of its facilities, and they've been working for years to improve their record keeping. The managers conduct monthly data audits, and looking at the most recent outpatient CPT codes, you can see that they still average approximately a 9% error rate. Now, you can't count, of course, on patients to perfectly recount their care and achieve the same quality that coders can achieve. Studies do show that patients have high enough specificity and sensitivity to add value here. The last example builds on Trish Torrey's point on medical errors that Dave called attention to. In this case, it's about laboratory studies. A study of closed malpractice claims looked at this type of errors. In that study, approximately 1 in 8 malpractice claims that were closed showed patients not receiving a test result with similar results for providers. Now, of course, it's unlikely that patients can recall accurately their laboratory test values in detail, even if they did see them, but they are still capable of identifying completely missed laboratory study. So based on quality of care, the case is strong for encouraging patient input. So let's look at how systems are currently enabling patient feedback. So on the next slide. As Priscilla told you, in order to understand the state of practice in patient feedback, we work with the staff of 8 integrated delivery systems shown here to analyze their patient portals. We looked at 10 categories of medical information ranging from medication lists, which all 8 portals present, to clinical encounter notes, which at the time we did the study in late 2010, none were presented. As you can see at the table on the right, portals either acknowledged on the appropriate form the potential for data quality problems and encouraged patients to contact their providers, or provided a mechanism to accept patient input online. We refer to the latter as facilitation. You might think of it as essentially providing a feedback button on the screens of the portals. So for example, for medication lists, 2 organizations provided text that encouraged patients to contact their doctors, and 3 others provided online tools to facilitate feedback. You can see that the majority of portals either encouraged or facilitated feedback for medication lists, allergies, and immunizations. So let's take a look now at how that's been done. Next slide, please. Encouragement is the easiest to add by simply including text on the form. For example, Beth Israel Deaconess patient site portal included this message on their medication list form shown here exactly as it appears. You can see that they encourage the patient to call or email their doctor before making any change to their medication, and most importantly perhaps realize that they present to the patient the fact that they're trying hard to make sure that the information is correct, thereby, we hope, encouraging trust in communication between patient and doctor. Now, facilitation comes in several forms. It's typically aspects through an embedded link on the screen, hence the idea of a feedback button. On the immunization screen includes this message: if inaccurate information appears below, please click here to advise us. Clicking there produces a screen which is shown at the right, and the patient enters text. Now, because it's identified as an immunization update, the software in the portal supports special treatment, resulting in activity that we're going to describe later. So next slide, please. A distinct take on patient feedback is shown by my Children's portal at Children's Hospital Boston that was put in place with the help of Dr. Ken Mandel, who will be talking later. My Children's combines the hospital's EHR with personal health records capabilities with which many of you are familiar. When the patient or the patient family sees the information through the portal, they have the opportunity to edit many areas of the record, problems and procedures, as well as medications, allergies, and immunizations. When they select that option, instead of an email-like form, they're shown a structured form specific to the category of information they wish to update. You can see an example of the medication form at the right there. They can enter specific information, often through selecting from drop-down menus. Next slide, please. The changes the patients or their families make are not entered into the official record, but instead kept alongside that information. When patients or providers use the record, what they see is a combination of the information with a symbol identifying the source. We have here an example from their demonstration. You can see the icons used to identify patients and providers enter data circled at the lower right. This particular example only has hospital records for laboratory tests. All other entries are made from the patient, which makes it look unusual. But the idea is that this gives the provider the opportunity to see the latest information from the patient alongside the hospital record. The provider can modify the official record if he or she wishes. So as you can see, there are a variety of straightforward ways to encourage or facilitate patient input. The question needs to be asked, what barriers need to be overcome to put patient feedback in place? Next slide, please. As Priscilla said, we interviewed a series of stakeholders in healthcare ranging from patient advocates to medical records professionals. We asked a series of questions on the adoption of patient feedback in general, not stressing the problems, and received considerable feedback from each of the interviewees on the barriers to adoption. As you can see on the right, the majority of issues to be overcome are on the provider side, not the patient. This list includes barriers identified for general online communication between patients and doctors, such as the most common barrier, the patient workload, as well as inappropriate use of the communication channel and the lack of compensation in the current payment system. Some barriers refer to technical issues, such as the difficulty of recording corrections in the current EHR system, or as Dave talked about, propagating corrections to all relevant records. Advances in EHR systems, introduction of the appropriate metadata, and health information exchanges will help reduce these barriers. What we found in successful organizations who have adopted patient feedback was a pattern that helped reduce the workload on the doctor and allow needs to be mediated by an appropriate professional before being entered into the official record. They have created triage processes that put professionals in place to mediate the process and deal with feedback. For example, if you remember the Palo Alto Medication Foundation form from immunization update, it's actually routed to a nurse who deals with all immunization updates. Our team's experimenting with pharmacist mediation at Geisinger Health Systems, where the pharmacists receive the input and they communicate back with the patient if necessary before making the updates, on occasion finding that the patients have given them incorrect information, perhaps changing the patient's behavior. Finally, the list also has a lot in common with the barriers faced by other industries who've dealt successfully with consumer feedback on air. My colleague Ethan Cash will be describing what we learned from progress in those industries and present a checklist that you can use in your own efforts to integrate patient feedback. Ethan?
Thank you, Norm. We have the next slide. When first reaction people have when I talk to them, usually about correcting errors in EHRs, is that we have HIPAA. We have a right to look at medical records, our own medical records, and we have a right to request amendments. Unfortunately, I tell them, this isn't really enough. It's certainly valuable to have these legally recognized rights, but it's also important to understand whether the rights are being exercised, and if not, why not? We all, for example, have a right to free expression, free speech, or press, but it used to be costly to distribute information widely. As the quote from Liebling at the bottom of the slide indicates, exercise of free speech right requires that you have a press. Now technology has made it easy and relatively cheap to publish information, and the right gets exercised more often. Bloggers, in a sense, own a printing press. It's certainly better to have a right than not to have one, but if we think the right is important, it's necessary to understand whether it's being used, and if it isn't, why it's not being exercised. We may, as Aaron indicated earlier, have 1 million fact checkers, but how many of the million are actually checking facts? And probably more importantly, if they do check facts and they find mistakes, what recourse is there? What can they do? Could I have the next slide? The challenge here, I think, is how to make the right meaningful. When medical files are in manila folders, but patients don't look at them, I ask people frequently whether they have ever looked at their medical records, and maybe 1 in 50 has, and that's usually in the context of changing doctors and carrying the file from one office to another. In my own case, like Dave, I have an EHR with Beth Israel in Boston. I never once looked at my medical record when it was in paper. I now look at it often. Since the first time I did look at it, I found an error. I had a right before, but in reality, it was not a meaningful right. And in my own thinking, one goal of meaningful use is to lead us to meaningful rights. It's not really a meaningful right when it's hard to correct something, particularly when we could make it easy. The goal is important, and it becomes increasingly important as more and more information about us is stored in electronic form, and the amount of information about us grows and is communicated. Next slide. Leave this slide, please. I'm sorry. This is not only an issue for medicine. Data quality is important in all of our electronic records. In other words, take the H out of EHRs, and you end up simply with ERs, not emergency rooms, but electronic records. As individuals, there's no shortage of ERs, electronic records about each of us. And the quality of data and the challenge of how to improve the quality of data in these records is widespread. Medicine is ahead in one respect, since we have a right to look at our records. This is indeed different from other records about us, such as Google's list of searches we made during the past year, or whatever it is that Facebook is now collecting. Medicine is also ahead in that we know that there is a record about us. Many, if not most, of the records out there about us we aren't even aware of. But many records about us we are aware of, and we can learn something from the holders of such records and how they handle data quality problems. In some of these situations, we have more of an incentive to try to correct the problem than in others. The more you take advantage of online banking, the more you are likely to check bank and credit card statements. I would hope that you would look at your credit report. You do have a legal right to a free look at your credit report at each of the 3 credit bureaus. I'm not talking about the advertisements for freecreditreport.com, which is a private service, but go to annualcreditreport.com. It's the only absolutely free credit report site. And it's an example of how you have a right, and then you have technology making it possible for you to exercise that right easily. The credit bureaus on their own home pages list online dispute resolution as an option if you notice an error. The most widely used error correction process is handled by eBay. If you sell anything on eBay, your feedback rating is valuable to you, indeed critical, and affects whether potential buyers will do business with you. eBay recognizes that providing a process to correct errors makes potential buyers more willing to make a purchase. There is less risk if you know that any problem that occurs will be resolved. eBay is a huge site, and last year handled over 60 million disputes of various kinds. Data quality problems are inevitable. There was the issue of my name being misspelled on emails and other material being sent out and posted. The good news is that the error seems to have been fixed in a matter of a few minutes before the webinar, so that on the first slide, the name was spelled correctly. Frankly, I'm not too worried about this because the error gets corrected automatically. Anyone who looks me up in Google and misspells my name, somehow Google sends them to the right place. One more slide, please. These are some examples of both the reasons we have errors occurring and some lessons from the eBay PayPal experience on which we need to build. These are not the most complex of problems, but admittedly, these are usually factual questions that have to be determined, and our medical records sometimes are not, certainly not as easy as fixing dollar figures or other reputation things. Next slide, please. This is a screenshot, one of the screenshots showing how PayPal solves its problems. The forms eBay uses manage communication, and that's something patients can judge. Undoubtedly, medical records are more complex, but they're certainly not an impossible set of issues. Next slide. This is my last slide, and some of these challenges are identified. This is an important checklist, I think. All of these elements involve information issues. Some require better communication. All require good design so that those affected will be able to use the system easily and will have incentives to use the system. All involve software and the challenge of providing ease of use, modifications, providing a clear record of how and when changes occurred. Again, it's not only what the system makes possible that's important, but whether it's actually being used meaningfully and is improving the data over time. In other words, there's a lot of work to be done. Priscilla?
Thanks, Ethan. Our next slide. So in wrapping up the talk today, it's clear that there's data quality issues in both paper and electronic records. My presenters before me have spoken about this. There are numerous reasons cited for this, some of which we've covered today. And giving patients access to the information and providing opportunities to obtain feedback on the accuracy of that information is important and something that is desired by both patients and providers. However, one area of work that is, that remains is also tackling the issues of the data quality at the source. As part of the study, we've identified 3 areas of high value for data quality improvements, and these include medication lists, allergies, and problem lists. So, future work should be looking at more systematic assessments of care delivery processes to see how, at the source, processes can be enhanced to improve the quality of the data. And there has been work done, so really this would be to build off what has, already been learned in this field. While there is progress being made by large organizations around patient engagement for obtaining feedback, it's clear that there appears to be some consensus amongst large delivery systems on the data that should be made available to the patient, but little consensus on the approach to both gather feedback and then process it. Given this, it seems that conducting limited pilot studies to identify best practices in how to gather the feedback and then how to process this downstream, would be valuable. At the beginning of the discussion, Erin mentioned a study that's going on at Geisinger, and we're collaborating with Geisinger on this, and we're hopeful that there will be interesting learnings from this pilot initiative. Other areas include research on different triage models that automate as much as possible the process of information flow between providers, between patients and providers. We realize that these processes cannot be completely automated, and that's certainly what our environmental scan has shown, but there are lots of efficiencies to be gained from automation at critical points. And all of these activities, we believe, can potentially inform more specific and incremental requirements under meaningful use and what is needed from the vendor community to support the market. We've mentioned the issues of mapping HIPAA rights from paper to the electronic world. And given this, some areas for considerations are the right to view the medical record and the right to amend. we learned that there's great variety in how EHR and how information is amended within the EHR and how software developers design the functionality. So the changes in the medical records can be represented in different ways, including crossing out old information, putting the old information in a different color, linking to the old information, but ultimately ways in which, corrections can be made and the information that has been changed is clearly marked, but does not clutter the provider's sort of processing of that information. Also, when patients provide feedback, careful consideration needs to be given to the classifying of the different types of changes that are requested to the medical record, and what are the kinds of changes that are of sufficient import to trigger the right to amend under HIPAA. So in summary, there's a lot of important work currently underway in different areas of healthcare and outside, but really more needs to be done to accelerate progress in this area. And with that said, I want to thank you for your attention, and I'm going to hand it over to the next speaker, Ken Mendel. Thank you.
Great. Well, thank you. And I've learned a lot listening to the speakers before me. I'd like to take a look at how we can make some of these desiderata possible in terms of how do we get information shared between patients and providers. How do we get patients a copy of their health information in a way that enables the kinds of interactions, error correction, an extra set of eyes on the data. Next slide, please. So the personally controlled health record is one of the technologies I've been working on for quite some time. I'd like to tell you a little bit about how it was diffused, why Google Health, which created one, died on the vine, and then I think the cure for personal health platforms that will permit this kind of patient participation in managing the quality of their data. Next slide. So broadly speaking, there have been two technologies that have been used to get patients a copy of their data. One is portals, and a lot of what Dr. Sotheimer showed in his review were portals that give patients a static view into the electronic health record. Most of these portals are software that's provided with the electronic health record software. It usually doesn't give the patients very much interactive functionality and is limited to certain types of web page views that were imagined by the vendor and often not very modifiable. Personally controlled health records, though, are really apps platforms and also provide a copy of the data for the patient that enables them to both store it, use it, share it, and also to expose it to apps. Let's go to the next slide. So we wrote about this in some detail in the New England Journal a couple years back and suggested that there would be tectonic shifts as Google and Microsoft and others got into the personal health record space, because now patients would be capacitated with their own data to do things like get into understanding its accuracy, to use it for things like medication reconciliation, as was mentioned, and also to even be able to share it for epidemiological inference. Next slide. The personally controlled health record looks something like this. In the middle is a platform, and the platform is where you get a copy of your data. At the bottom of the slide, what you can see is that the data can come in from all kinds of places. In portals, the data usually comes in just from a single electronic health record system. But in personally controlled health records, the data can come in from different hospitals, different practices, laboratories, pharmacy. And then on top, what we used to call an ecosystem of applications. These are apps that are created by third parties that use your data. and can show you graphs of those data, could show you potential errors to correct, could have a shared editing tool for doctors and patients to perform some of the functions we're talking about. These apps, we used to call it an ecosystem of application. Now we refer to it more like an app store because people know exactly what we mean when we talk about a store full of apps that have access to a limited set of data but can perform all kinds of functions. Next slide. So if one is using a personally controlled health record, there are a few verbs that one engages in. One is called subscribe, and that's where you get a copy of your data by subscribing to it. Next slide. Now, we used a model that was very much like Quicken, where one can go, if one wants to manage one's finances, and download data into one's Quicken software from bank accounts, retirement accounts, investment accounts, and manage it all in one place. Next slide. Next slide. And then another version of Quicken is one that's completely web-enabled. And this, again, like the iPhone being a very good analogy for what we were trying to do on the top of that personal health record diagram, Mint.com is a great analogy for what we're trying to do on the bottom. And in Mint, it's all web-based acquisition of your financial data. And if Mint goes to the equivalent of a health portal in the financial world, your retirement account portal, and if that retirement account vendor is not making the data available in a standardized format, Mint just uses a technique called screen scraping and grabs all the data right off the page and puts it into a database where you can use it. So Mint actually achieves this integration of information across sites, despite the fact that these financial organizations don't necessarily work together. Next slide. Now, in health, there has been a problem because patients have had trouble getting copies of their data to do this kind of participatory, these participatory actions that include ensuring the quality of the data. For example, in health, there's something called the Direct Project. It's a nascent project. It's run by ONC, but it's an email system for health, so the data can actually get from one system to another in a secure way that's sensitive to the needs of the medical system. But it uses very fundamental email protocols, SMTP, which is the classic store and forward protocol we've been using ever since AOL and before. And also there's something called the Blue Button. It's an interesting experiment at the Veterans Administration where the veterans can push a button and get a copy of their data downloaded to a site of their choice. Next slide. The other things that are very important for this kind of interaction are sharing of data. So people with PCHRs can share data. Next slide. For example, here we had folks in an experiment we did and published in PLOS One a little while back. We allowed people to provide information, people with diabetes in an online social network of 35,000 folks with diabetes, to actually provide information about their glucose control called A1Cs, and to share it with the community. And there in the community it showed up on maps and graphs, and we got thousands and thousands of people all over the world entering and sharing data. They were very willing to do it. Click, please. In fact, 81.4% of the people were willing to share their data for quality improvement in public health, and 34% actually showed in a fully identified way their data on their own personal social network page. So people are willing to engage in these functions that we need to add data, to share data. Next slide. Next slide. And in a Veterans Administration study published in Annals of Internal Medicine a few months ago, they looked at this and found that 79% of veterans are willing to share personal health information with those outside their health system. 62% with a spouse, 23% with a child, 15% with another family member. Interestingly, though, only 25% with a non-VA healthcare provider. People are attached to their own healthcare providers. They're not necessarily willing to engage in this sort of data sharing and interaction with folks, with healthcare providers outside of their immediate health system and circle. But nonetheless, they're willing, 79% overall were willing to share data in some way. Next slide. So also, PCHR users can add an app. This is very much like adding an app to your iPhone, a very familiar action by these days. Next slide. Now, the nice thing about personally controlled health records is that they're very, very simple to implement, and we can get a lot of functionality going because, as we pointed out, it's the patients who are the ones who have the most interest in seeing that their health care goes smoothly. And it's also the patients who really need to have a complete copy of their data, whether it's to use themselves, to expose to apps, or to share with their providers. And in fact, the way electronic health records are designed, the data are stored locally all over the place and end up very fragmented. So Clayton Christensen, who invented the concept of disruptive innovation, writes a chapter on the Indivo system, the system that we've developed for personally controlled health records, and thinks it's a very good place to begin thinking about how to have a low-cost, high-quality healthcare system where patients do have access to the data, where they can engage in these kinds of activities, and where they can share the data with their providers, and where they can get a complete copy of their data. Next slide. And so what's happened with the personally controlled health records? Well, you know, there's been a very interesting progression. The Indivo model, we exposed it in 2006 to a whole bunch of industry players and government players, including Microsoft, Google, and a bunch of employers, and some interesting things happened. We suggested that the model of storage of data should be very inexpensive or free, and that the business model and the interesting things happen up in the apps. Microsoft didn't do open source, so they took our software code and stuck it into a product called HealthVault. Google, which didn't use our software, implemented the precisely same model, and they called it Google Health. Dacia, a consortium of large employers that includes Walmart, AT&T, and Intel, contracted with us, and we built out Indivo itself for hundreds of thousands of their employees. Next slide. Next slide. Oh, I don't have the controls here. Oh, there we go. Okay. So the Google, however, died on the vine and shut its doors on December 31st of 2011. Why is that? Next slide. Well, a couple of things. I actually discussed this in detail on NPR, but here, I think briefly, there were trust issues. Do people want to store their data in Google? There were really no app developers working for Google to create what Steve Jobs had created for the iPhone and what personal health platforms are designed to enable for health. And the data didn't move. I've talked about the Direct project, the Blue Button, but overall, electronic health record companies have only exposed data in these very limited functionality portals and haven't let the data out. In the portal, there's only so much of these kind of activities that you can do in a satisfying way that will actually, I think, be adopted on a large scale. Next slide. So I would like to talk about briefly an approach we're taking now that we think leads up to a hybrid approach between portals and personally controlled health records. The Smart Platforms Project is funded by ONC. It's part of a program called SHARP, which is ONC's electronic health records research program federally mandated under the HITECH Act. SMART is a $15 million project to design the App Store for Health. Let me tell you a little bit about it. Next slide. Here's a motivating use case. So Medtastic, this is a made-up company, is a well-funded new company that's developed an elegant medication list application that has physician and patient-facing, consumer-facing functionality. Patients can annotate medication lists for accuracy. So this is exactly what we're talking about. But how can this company sell its product broadly? To work, it needs a prescribing history, it needs dispensed medication history, it needs allergies, it needs probabilistic diagnoses, so it needs a whole bunch of data. A lot of things that often Google Health didn't have. And it also needs access, to be able to provide access within a health system or practice to doctors and to patients. Next slide. So in healthcare IT, it's often the case that innovators like this fictional company, and by now there are actually several companies just like it that we've met in the real world, they can't very easily sell their product. They can't innovate quickly within IT systems, and providers and patients can't request new features and applications because electronic health records tend to be very static pieces of software that are very hard to modify, and that includes the portals that come with them. Next slide. It's getting there. So we imagine electronic health records as an iPhone-like platform where a company like Medtastic could create and widely distribute an app across many disparate electronic health records and personal health records. Next slide. So in SMART, there's what we call a common application programming interface. That's what Steve Jobs provided, and it makes it to his developers, it makes it very easy for iPhone developers to make iPhone apps. That's why there's 600,000 of them. Software developers can build what we call substitutable apps. The beauty of substitutable apps is just like the apps on your iPhone, you can delete them if you don't like them. If a better medication reconciliation app comes along, you delete it and download a better one that better enables patients to annotate, one that better presents the data to patients and physicians, for example. This pushes innovation to the edges. It gets it out of the we're not entirely dependent on what happens in the handful of EMR companies that dominate the market, or across the 700 EMR companies that now sprawl more than 1,750 different products across the health system that are certified, actually, for meaningful use. So this lets us to nimbly evolve functionality, avoid vendor lock, shrink switching costs, and enable disruption, the good kind of disruption, disruptive innovation. This lets us have functionality that's very rapid and physician and patient facing. Next slide. So here's just an example of how we use this. Wired Magazine had a contest, and they commissioned folks to create a vision of what a really good laboratory information display would look like, one that was either physician or patient facing. And it was one of the future. So this particular image of a laboratory information display by Dave McCandless, released it under Creative Commons license, shows you a cardiac risk score, an interactive graph. It lets all these numbers change when the numbers of your cholesterol, CRP, your age, your smoking status, all that changes. But this was a picture. This was just a picture that was drawn and then published in Wired Magazine. The editor of Wired used this in TED Talks, and it was very inspiring. Next slide. In 8 days, we took this image from Wired Magazine, released under Creative Commons license, and we turned it into a real live working application, getting real data from the electronic medical record. Next slide. In fact, not only from the electronic medical record, but also from the personal health record, from the very same Indivo personal health record that Norm showed working at Children's Hospital Boston. And so here we have the same app, unmodified, with patient-facing and physician-facing functionality. This can run across a whole series of platforms. Next slide. We created an app for kids with high blood pressure, and we're running this at Children's Hospital now. It lets you graph blood pressure over space and over time. People who have seen electronic medical records know that this kind of functionality and graphic interface that we created in a few weeks isn't present in electronic medical records. Here's a way that we can look at data in a useful way. So there's the idea that we can edit our data over time, but we can also visualize our data over time. These visualizations are designed more for doctors, but one could easily imagine how this could be simplified in a way a bit more comprehensible for a patient to show when one's blood pressure is in or out of control on particular dates over time. Next slide. And how medications affect it. We have another app that lets us see how adherence is, who's picking up their medications, who's filling their prescriptions. Are we being adherent? This lets us have a shared view between doctors and patients of how medications are being used at home. Next slide. So in this New England Journal, we wrote about this idea of substitutable applications and that we need liquid data filling the platforms. We need substitutable applications, and this stuff should be, we think, built to open standards, and there should be very diverse applications. Next slide. We actually ran national contests. The White House was very involved in promoting them last year, and we got all kinds of great apps developed in a challenge.gov challenge for the SMART platform. Next slide. And so the SMART platform apps, they have access to EHR data in a vendor-agnostic way, so that these apps could run on an Epic system, a Cerner system, a homegrown system. And so far, one can readily create a patient-facing portal now, which is an apps platform. Let me just show you briefly how that looks. There's a lot more detail to go into, but we'll start to wrap it up. Next slide. If one now is able to get data out of EHRs all over the place, like we showed, and run the same functions on EHRs and personal health records, the same apps, now one can easily imagine getting the data out of an electronic health record and sharing it with a personal health record, running these kind of smart apps on top, and very readily having a personally controlled health record that has so much more functionality than a flat portal, that actually, unlike the Google Health, which died on the vine, and unlike Microsoft Health Vault, which is having trouble getting data, this comes with the data because it's linked to the EHR. The reasons portals have been very successful, even though they don't have much functionality, is because they have the data. But now we can potentially think about very richly functional portals that either keep the data within a health system or share data across health systems using that Quicken or Mint-like function. Next slide. So if people are interested in this from a developer's perspective, we're actually having a conference about it next month. I think these slides will be available, and the URL is posted. And the next slide, please. And there's also quite a bit of information about the apps platform, the ONC-funded project at smartplatforms.org. Thank you.
So Erin and Lygia, were you going to make any final comments before we jump into the Q&A?
Sure. Hi, Kate. This is Lydia
Hey.
and Erin. A couple things that we wanted to say. First of all, thanks again to the presenters as well as all of our attendees today for participating in this conversation. Regarding the NORC study that Priscilla and Paul presented, we will be publicly publishing those results sometime this summer. So we will be sharing those more broadly, the full study, and so keep an eye out for that. we also just wanted to say from our perspective with regard to that study in particular, although this also applies to some of Ken's work at Sharp and other work, a lot of this is intended to inform some of the future stages of meaningful use policy. And in case folks are not aware, meaningful use is open now. Public comment for stage 2 of meaningful use is open. We're accepting comments until May 7th. So if people haven't commented, you can easily do so at regulations.gov. We're not allowed to comment in detail about what those provisions suggest, but there is a whole section that's related to patient and family engagement. And so even if you just wanted to make a very general statement about what you think is important or not, without getting into the details of the proposed regulations, you can do so at regulations.gov. So I would really encourage people to do that. And I would also emphasize that those need not only be sort of negatives or tweaks about how to switch what's already proposed, but also where you think appropriate support for plans that have already been laid out. So, a plug, once again, to comment on meaningful use by May 7th at regulations.gov. The other thing I wanted to mention that's going on in our world in the very near future is participation in a major conference called the Health Data Initiative, which is going to be June 5th and 6th here in Washington, D.C. And our consumer e-health program will be running a several-hour track on one of the days, the 5th, in which we highlight a number of organizations and companies and individuals who've made real contributions to consumer engagement in e-health, and also make some new announcements and issue some new challenges. So if you're able to join us for that, that would be great. That's it from the ONC side.
All right, so we do have quite a few questions that have come in, and we have, about 15 minutes or so, so I'm just going to start rolling with the questions and try to direct them as best as possible and give the panelists all an opportunity to comment. One question we had relates to a common challenge I think we struggle with, and this is how do we decide when to call people consumers and when to call them patients? And maybe Lygia or Aaron, if you want to start, and then I'll give ePatient Dave a chance, and anyone else who wants to comment on when do we say patient, when do we say consumer?
Okay, so we've chosen the word consumer to apply broadly to the work that we're doing because I see it as wider. We are all, every single human being is a consumer of health information in one way or another, even just you know, whether it's a conversation with your doctor or understanding, you know, choices about what you do in your daily life. Everybody's a consumer. Patients are people, in my mind, who are more immediately involved in the process of healthcare, and they're under the care of a particular clinician or other provider. I think our approach is to be inclusive. Certainly, patients have the most extreme need in many cases. Guidance and assistance. We want to open the world up to consumers more broadly, too.
Dave or anyone else want to comment on this?
So I've blogged about this several times, and to make a long story short, it all depends on context. And right now the culture is changing our view of who plays what role in healthcare. And that means if you look at any transaction through one filter, I look like a patient, and if you look at it through another filter, I look like a consumer. And my only concern about it is that people get upset when somebody speaks from one context and it's heard in another. And what I would encourage everybody to do is open their mind to the idea that as we look at things differently, it will all look different, and it's all good. Just keep moving forward.
Any other comments on this, maybe from the perspective of the NORC project in terms of the context that you used, that patient or consumer terminology? Priscilla or anyone else?
So this is Priscilla from NORC. You know, when we approached the study, you know, given that I think we were sensitive when we were sort of engaging with the provider community. There was very much a thinking that, you know, the view is that of the patient. But, you know, certainly in our interactions with individuals that were more aligned on the consumer side, so like the consumer advocates and things like that. It seemed that the consumer sort of context was the more appropriate one to use. So there almost seemed to be like a difference of perspective depending on, who the healthcare player was. I mean, that was my perception. Ethan, Norm, do you want to add to that?
No, that's great.
Very good. So we'll move on to the next, and I think it was Norman who maybe commented on this. We did have a question about, what rights patients have under HIPAA to annotate their records and to note that there may be an inaccuracy. But I think I remember one of you saying, yes, that's a right, but it's not quite enough. Could you just reinforce that point?
Yeah, this is Ethan. I think I'm probably responsible for that. I think if you look at, rights in some respects are a minimum. We like to have more than simply a right. We'd like to take advantage of those rights. We like to exercise and use those rights. The example I gave was about free expression. 30 years ago, we would have been quite satisfied with some corporations owning printing presses and some of the rest of us simply being consumers of those presses. But we're not satisfied with that anymore because the technology has changed. So the framework around many rights that we have is certainly being changed by the capabilities that technology provides for us. I don't know if that's clear enough.
That's very helpful. And sort of as a follow-up, and I think this is directed to ONC to some extent. So the comment is for patients to really be able to provide meaningful feedback about the accuracy of their records, they need access to the full record as opposed to the partial information that might be available through a portal. So what can we do, or how does ONC intend to try to encourage providers to give patients more full access to their records for the purposes of checking accuracy?
So I think it's a really important question, and thank you for asking it. There's long been a lot of debate and pushback about how much access to what information patients should get. In general, I will say through a variety of avenues, we are on the side of encouraging that patients have access to more, if not all, information. For our pledge program, for example, through which we are encouraging organizations that hold data on patients, whether they're provider organizations or payers, to make information readily available. We're also moving in, again, I can't really comment on meaningful use, but it does address access to information. I think there are some interesting studies underway. One that I know that ePatient Dave, among others, could comment on is the Open Notes project, through which there's a question about not only giving patients access to what's written in the medical record that the doctor may have or what's traditionally available through the portal, but also the notes that the provider keeps about the patient. And Dave, you have some experience in terms of outcomes of what that kind of access yields. Do you want to comment on that?
Yes, long story short, because we're short on time, it's wonderful. I was able to, even in a simple case without an emergency going on, a couple of weeks after my first appointment with Open Notes, I thought, shoot, wasn't I supposed to follow up on something? I had no idea where the printouts were that I brought back, and I just went and looked online, and I found it. Oh, yeah, I'm supposed to look into this potential skin cancer thing. And who wants to argue with that, you know? And the full results will be published later this year, but the few doctors I've spoken with who were involved in it say that the great fear that the world would go to hell and doctors' lives would get out of control if patients could see the record has not, for them, materialized. So I'm optimistic that when the rest of the data comes in, we'll see that this is a good thing, unquestionably.
And just to comment, we actually did, NEHIC University did a program last week on the Open Notes project, so the recording of that is available on our website if you're interested in hearing more. It is a really interesting project. One more question for Priscilla. You had a slide, I believe it was you, who had a slide that ranked the the barriers to sort of this information sharing with patients and accuracy checking. So was it a surprise to you or the team that confidentiality and security was actually at the bottom of the list of barriers?
So this is Priscilla. I don't think we were surprised by it because we've done other work. We've looked at the literature, and in many cases, the sentiment that patients want their information to be accessible to those who can help provide better care for them. It's sort of the general sentiment that pervades. So, from our perspective, we certainly thought it would appear on the list, but I don't think we have this preconceived idea that it would be high up on the list. And then our study, again, validated not just what we've been doing here, but certainly information that has come out from, Project Health Design and other initiatives as well. Norm, did you want to comment?
No, that's exactly right.
Very good. The next one is for Dr. Mandel. And you talked a lot about the personally controlled health record, and it's a great platform. Can you comment at all on to what extent this is available today and what it will take to make it, for that to become a more widely available solution or platform?
Yes, that's actually a key question, and I think even 3 years ago, it would have been difficult to predict that despite the emphasis on data liquidity and electronic information, that the electronic health record vendors would resist so vehemently allowing the data out of the records for patients to obtain a copy or even often a view. There's a lot of concern from a commercial perspective on when the data leaves those records and gets into the hands of the patients, because there's a sense that may weaken the market position of an electronic health record company that likes to control the data. So because of this, companies like Google and Microsoft actually had much more trouble than they anticipated filling the records with data. And now I think there are a few opportunities. So there are ONC-funded data liquidity projects like Direct, which is this email system, which is designed to move data around. There are these new programming interfaces that we, I think, need to really think about having running on our electronic health records or near them so that we can pull data out and use it both for clinician-facing and patient-facing applications. So the model that I presented, where we actually have a richly populated but highly functional personal health record residing, even very closely linked to the data resources of a particular health system, is one model where something like this could happen. But it's the third model is health information exchange, and that's where usually a central organization manages information flowing between institutions, and there would be the possibility to run something like a personal health record off of the data from the health information exchange. But we haven't seen that emerge very successfully yet. So the emphasis, I think the key to success, is on finding the right model for the data to be flowing towards the patient into a highly functional platform.
Thank you. It seems like things are starting to move much faster, but there's no one way to do this yet, which kind of makes sense. So we had one question about how much extra time, and maybe for the research team, I mean, do we have any kind of sense of how much more time it takes the staff in the physician office or in the hospital to try to address these issues with inaccurate information flowing?
We're collecting that data, and we'll have it to report.
Very good. Thank you. Let's see.
So this is Lydia. I have a comment on that. Anecdotally, there's at least one of our providers who was one of the first to reach meaningful use, that's Dr. Chris Tyshen, who talked about how having patients entering their own data into a system actually saved him and his own office staff time. It's true that there might be more time associated with addressing or correcting errors or omissions that are found, but on the other hand, you're basically harnessing a free resource from outside the healthcare provider's office to provide new content and ideally really good quality content. So it's just something to think about.
And I'll add on to that. The very first paper that was ever published about using computers to capture medical information in 1968 talked about having the patient do some of the data entry, and also noted that when the patient was watching the doctor do it, the patient spotted a typo. So we have this mythology that this stuff is sacred and only the saints and priests can touch it, but it's silly. I mean, let's catch up with 1968.
I think we have time for just one last question, and I think this is sort of a comment and a question. So the comment is, the attendee says, it strikes me that payers are also motivated to ensure that the data is correct. Has there been any aspect of the research that looked at engaging the health plans in trying to ensure the data accuracy?
So this is Priscilla from NORC. For our study, the focus has been more around sort of the provider-patient sort of engagement. I mean, it's certainly sort of an interesting avenue to pursue, and definitely probably the basis of hopefully some future work. But we did not do an extensive sort of review of the payer side for the study that we're reporting on today.
And this is Dave. I'll say that while I haven't studied this in any depth, my own subjective experiences, I was quite surprised. 3 years ago when I accidentally tried to move my insurance records into Google Health, what came across was garbage, and it turns out it was full of errors. And I thought that the insurance company's audit department would be all over it looking into things. I never heard a peep from them. And what I've actually had several people point out to me realistically is that insurance is, whether it should or shouldn't be, insurance is a cost-plus business. And it's just not a problem when costs go up because their 5% off the top goes up too. So that's one. People I know who have learned to dig deeply into their insurance billing statements have found many, many mistakes and not much help from the insurance companies at getting them fixed.
Well, Dave, we're going to have to let that be the last word since we're out of time. I really want to thank Lygia and Aaron with ONC, as well as all of our panelists there and our attendees. There have been quite a few questions we could interest in improving this whole process, and maybe we need to do another program on this topic, so we should think about that. But so thank you, everyone. Fabulous presentations and conversation, and thanks for joining. We are going to, we hope that you'll join us, many of you, for our May 15th program on innovative consumer engagement in behavioral health. And thank you once again. And when you sign out, there will be a survey that will pop up. So please do take a moment and complete that for us as well. So thank you, everyone, again, and have a great day.